Bonsoir.
Good evening, everyone.
Bienvenue.
And welcome.
Bienvenue à tout le monde.
Welcome to everyone.
Alors nous sommes très heureux
We are very happy to welcome you
belle
here
salle
to this beautiful room
Tokyo
in the Palais de Tokyo
tous ensemble
to celebrate together
de fonds.
the fundraising evening of ALIMA.
Je suis très ravi parce que Kadi
So happy
a accepté.
that Kadi has accepted to run the evening with us. Thank you, Kadi.
Je voudrais aussi remercier tous nos
I'd also like to thank all of our partners who accepted generously to support the organizing of this meeting in Paris, Dakar, and in New York. Thank you. Thank you, Dr. Moumouni. Good evening to all. I'm very touched to be with you tonight and to join the wonderful ALIMA adventure. Very touched for several reasons. First of all, for personal reasons, because my roots are in Chad and my family lives in N'Djamena. And I'm also very sensitive to the action of ALIMA, who works hand in hand with Eluja. It's fundamental, and we'll be getting back to them all evening. Tijan is in Dakar. He's with our teams locally there. And Dr. Shepard is with us as well in the United States from New York. And all of you who are following us online, just about all around the world via internet, and those of you who are here with us in Paris. Thanks to all of you for being part of the new Humanitarians.
Alors, merci beaucoup, Kadi.
Thank you, Kadi.
Alors, les nouveaux
The new humanitarians are the heart of ALIMA. The new humanitarians are the men and the women who work every day in the field to save lives, sometimes at danger of their own lives. The new humanitarians are also you who have accepted to be in this room. There are partners, fundraisers, and donors who enable us to save lives on a daily basis. I'd like to remind you that ALIMA is built on a model based on two pillars, the first of which is a partnership with local NGOs, which enables us to have a long-lasting activity, and secondly, research and innovation, because thanks to research, we're able to continue. It's thanks to research that there are innovations that ALIMA has been able to discover new molecules today that are active against Ebola. I'd also like to underline the real need. We are here to present the important needs that we have in Central Africa and Western Africa. These needs are even more pertinent today because of the various crises. You know about all of those. That has led us to reinforce health measures for this evening's proceedings. There are conflicts on in our land that also requires additional humanitarian help. We have thousands of children that need care, thousands of children that need humanitarian action to be able to just live. I'd also like to say that that's the reason that we're here. We're here because it's very important to have your gifts, your donations. So we're happy to present the work of ALIMA this evening, which is very important. We're going to be focusing mainly on one area. Kadi is going to get back to that to show you what our teams are doing on a daily basis. Throughout this evening, in three continents, in Dakar, Paris, and New York, we are going to be mobilized to raise 1 million euros to support the three funds that were set up by ALIMA with the purpose of doing our work better. And as I was saying earlier this evening, we're going to be bringing you to Chad. That's the red line this evening. In the N'Djamena project, we're going to be going into the field to understand how ALIMA is transforming humanitarian medicine. Let's have a look. Here in Chad, the Jamena project is covering malnutrition, and for countries around have problems as well. The problems that we know because of mercenaries and rebels in the area, in Sudan, with what's going on in Central Africa, and the situation in Chad and the Lake Chad Basin with Boko Haram, which is this is a problem between urgency. Between 40 and 45 years, we've been hard hit in Chad. This whole area, we have displaced persons. We're working with the NGO, Chad and Jamena Health, and with the ministry, because we always provide support for the structures that are already there. The partnership, Alert Santé, makes it possible to facilitate relationships with authorities, the administrative authorities, and to facilitate meeting with the community. It makes it possible to make it easier to deal with the needs and the interventions that are appropriate. The partnership is the only solution to deal with humanitarian questions. We've just seen here, ALIMA is responding to a crisis, an acute nutritional crisis in an unstable country. It's a situation that the field teams know very well. Dr. Kader, who've joined us, he's Director of Operations for ALIMA. Good evening, thanks for coming. This year, 56 projects were carried out in 12 countries. Could you tell us how the ALIMA model allows for the implementation of these projects? Thank you for handing over to me. Hello, everyone. In fact, I'd like to start by saying that the slogan is the patient first. It means that from the heaven to the field, we have 2,000 people working on a daily basis with a single objective, how to help to take care of our sick people. And who are these people that we're dealing with? In fact, these are people that are ill because they're in conflict areas, in inaccessible areas. These are patients that without us would have no other possible way of having care because governments can't get in there. No nation can access that. Usually they're women and children. So the question is, how are we able to access the patients? And that's where what Dr. Soje is all about. We are in a partnership with local NGOs with whom we share the same values. That's where we say it's the ALIMA model. I'm not talking about what we call subcontracting. We're not partners in that way. We worked hand in hand with local NGOs, and that's a symbol to open doors. You talked about administrative procedures. It's not only that. There are all of the aspects with anchoring. And this is a really community anchor that know, and together we can get things moving and go to areas where other people cannot access. So the result of that is what? ALIMA, we're young. We've only been around for 12 years. For a big organization, we haven't been around very long. But if I give you a figure, in 2021, ALIMA was 1.3 million patients that have been cared for. Ella is 40,000 women that we've helped to give birth under optimal conditions, in secure conditions. ALIMA is 90,000 children suffering from malnutrition that have been taken care of. In addition to that, there are also 30,000 people that have to help people in need, without even counting information from the moment with respect to the COVID pandemic. There are 35 million doses that have been distributed for people in those areas, and I think that's not nothing. 300,000. So these figures seem huge. But knowing the field, the need is much higher than that. We need more. So we see what's going on. We're confronted with the limits of classical humanitarian aid. The usual institutions themselves are not able to do this. So these are choice donors. We have priority to certain areas at the expense of others, and it's very painful. We just talked with Njamia. There are thousands of children that are likely to die of malnutrition because we don't have the product that we need to cover them. This association, you'll see this in Nigeria and Niger. There are people that die from yellow fever. Nobody can finance it because that is the classical system. But we wish to avoid this. So what we don't want to watch these patients die. They need us. They need you, all of you here, and all of you who are watching. So together, we think that we can do something. We think that we can help save lives. That's the message I'd like to get across today and share with you, and that's why I came here. Thank you.
Merci beaucoup.
Thank you.
Merci beaucoup, Kader. Merci.
Thank you, Kader.
Merci d'avoir rappelé.
Thanks for having gone over those figures. It's very important. We've understood that ALIMA is mainly in very difficult contexts. These are territorials that are not very accessible. I would like to hand over, we'd like to go to Dakar. We're going to join Tijan. Hi, Tijan. Hi, Kadi, and welcome to the headquarters of ALIMA in Dakar. Kadi, I am here with Dr. Kanta on my right.
Alors, d'ALIMA au Tchad, en RDC,
and we're in RDC
au Cameroun.
And Cameroon.
Un grand territoire.
It's a very big area. Could you speak to us a little bit about the context in which you are intervening and what your operations are? Hi, everyone. As my colleague just said, we intervene in several countries. These countries are concerned by a crisis situation and a security question. So we intervene in the Sahel area and all of the countries in the Sahel where there are real problems of security. There are a lot of conflicts in the basin of Lake Chad. But other than those countries, we also intervene in Central Africa that also are concerned by rebellions and the RCA. There's also the example of the Democratic Republic of Congo. In these areas that are affected by crises, we're not able, the health centers are already fragile, but they're even more fragile because of the situation. And our teams in these various countries have to go fill in those lacks, those gaps. So we're far from the population. So for this to happen, we have to have a minimum of services to help them get through these crises. Essentially, women and children are targeted. So we take the risk. Why? Because we have to provide care to these communities. And our objective is to offer health services in people in the countries of Lake Chad, in Cameroon, Niger, and Mali, and the front line in these countries. And as we were saying, in the Republic of Congo, in mid-November, the situation of a conflict there, which broke out on the border of Uganda. So there's a lot of mobilization. And when there are crises, people run from the war, and we go into that. We send teams in there, in the conflict area, to help the community, because who else is going to do it? So that's what we have to offer to them. So we do help the local population whenever it is possible. But we can only do this if there are resources to access the population. Our resources are limited. We'd like to do more in order to be able to go help these people that are living in very difficult situations and that are very fragile. So these communities really need access to care. Thank you. Thank you so much, Dr. Kanta. I suggest that we go back to Chad to see how your work is reflected in the field on a daily basis. Let's have a look. Here, we always say there's a real nutritional problem. There is one door in and several doors out. We have children that have problems with malnourishment, but with complications. All of the children that come in are malnourished. The objective is really to detect and take care as soon as possible children that are suffering from malnutrition before they reach a critical phase. There's a huge number of deaths of children linked to malnutrition. We need to look at whether the child's life is in danger or not, and we obviously bring them immediately to intensive care where all of the physicians are there available 24/7. This year, all of the objectives that I was speaking about of detecting and treating children were interrupted in the pilot. So there's a big break during the peak period. There's a real problem with the health system to face up to the number of patients that were coming into the hospitals. And we saw a lot of children that did not have access to treatment this year. Most units refer children to us because we even have difficulties for treating. There are a lot of spontaneous situations because the hospital where we work has a good reputation, but care is free. And this year it was aggravated by limited arrivals of outpatient possibilities, and a lot of children just go home, and there are children that leave the hospital and that did not have access to the treatment when they leave. So we're back again, Dr. Momoni. For 9 years now, you have been working in the field. He was director for operations, and since February, you are general manager. Given these pictures, what do you want to say about what we've just seen? Thank you, Kadi. I'd like to underline the fact that I was a physician in the field, as the person you saw earlier on your screen. What I recall is the suffering that a doctor has if you can't help a malnourished child who's in front of you. Now, we have a peanut-based product enriched with vitamins without which we could not treat children correctly. Now, what I also recall is the suffering of these families, the suffering of the doctors and the nurses, and we are truly discouraged because we see that the classical system is not able to find the solution. So we're not able to find the solution. And we believe that we need a new way of leveraging the purchase of peanut products to avoid these children suffering more and to avoid the children that we take care of do not fall back into malnutrition. And how do we do this when faced with a situation like the one we've just seen regarding the lack of therapeutic food that are essential for the care of malnourished children? Are there new products? Well, what we do is we need to mobilize resources to find an emergency solution. And that's why we're here today. That's why we have this fundraising evening.
Faire cela nous permet
So doing
d'acheter
this
du plein
makes it
peanut
possible
en
to buy
urgence.
Plan
Comme
Peanut
tu l'as dit, nous
urgency.
travaillons aussi sur la recherche
And we work
et
on
l'innovation
research
qui
and
nous permettent
innovation, which
justement
makes it
de
possible for
trouver des
us
solutions
to
qui soient
find solutions
pérennes.
that
Alors, je
can be
rappelle
sustainable.
qu'avec la recherche
As a
donc,
reminder,
sur
with
les protocoles de
research
prise en charge,
on
nous pouvons, avec
protocols
ces mêmes quantités de plein
for
peanut,
care,
prendre le
we
double
can, with these
des enfants que
products,
nous prenons en
cover
charge
double
aujourd'hui.
the number
Donc,
of
nous avons
children that we
besoin
deal with
justement
now. So
de
we really
nourrir
need
les trois
to
fonds
feed
qui ont été
these
créés par
three
ALIMA, le
funds that
fonds
were created
d'urgence,
by
le fonds
ALIMA,
de
the
formation des
Emergency
talents, parce que
Fund
comme vous le
and the
savez,
Foundation
sans
Fund,
formation, sans
because
des
without
hommes
training,
qui
there's a
sont
fund for
capables de
training. And
prendre en
without
charge
that
la
training,
malnutrition et les
you have to have
repas
people
insuffisants,
that
on va
know
y
how to
arriver.
cover
Donc,
malnutrition
et
and
le
other
troisième fonds, c'est
pathologies. And the
évidemment
third
le fonds
fund
de
is
la recherche.
obviously
Donc, avec cela,
R&D.
nous
And
pensons
with
que
that,
nous
we
allons
believe
trouver
that we'll
une
be able to
solution
find
avec vous.
the solution
Alors,
with
je
you.
voudrais aussi
I'd
rappeler
also like to
qu'avec
just
50
remind you
euros,
that with
nous
50
allons
euros,
prendre en
you
charge
can
correctement un
treat
enfant
a
souffrant de
malnourished child
malnutrition et
in
de syndrome
ambulatory
et avec
care.
150 euros, nous arrivons à
And
prendre
with
en charge ces
150 euros,
enfants
we can
qui
cover
souffrent de
a child
complications
who's
aiguës
suffering
en
from acute
hospitalisation. Donc, toutes leurs
complications in the
complications,
hospital. And that would
nous
cover
arrivons à
all of the
sauver la plupart de
complications
ces enfants.
and can save
Merci
most of these
beaucoup,
children.
Moumini. C'était très important
Thank
de
you,
rappeler aussi
Dr.
ces
Moumini.
équivalences de dons. Merci à toi.
Thank you
Nous
for
proposons
telling
maintenant
us
de
how
faire
much you
un
can
premier
buy
point,
with your
sur
gift.
les promesses
Now,
de dons. C'est 3 fonds.
there were 3 funds.
Est-ce qu'on
Let's
peut
go
voir
back
un
over
petit peu le
those. Can we
tableau?
see that on the table?
Alors, c'est pas
On the
mal.
screen?
C'est pas mal.
Okay, great.
50 000.
It's a good beginning.
Ça,
Wait a minute.
voilà,
It's going
voilà,
up.
on est à jour. Ah, ça augmente pas mal.
It's going
Voilà,
up.
65 000.
65,000.
Ça augmente encore. Bon,
Great.
on verra ça tout au fil de la soirée.
We'll
Ça
keep
va
looking back
remonter,
at
c'est qu'un
the
début.
figures. This is only the beginning. We know that in countries where ALIMA is present, the big difficulty is the crying lack of care, medical personnel. In Chad, for example, there is one doctor for 25,000 people. In France, it's one doctor for 300 people. In other words, there's 80 times more physicians in France. So what response does ALIMA propose to overcome this? Let's have a look. This is a project that's been set up since 2017, subsequent to the observation of the fact in the field that we were lacking staff who knew how to use the protocol to treat malnutrition. You can even do this before. We created this school to train professionals, health professionals, so that they can be able to cover the malnourished.
C'est la suite qui compte. Il peut encore faire un choc s'il continue à faire la diarrhée.
He still has diarrhea. He could be in a state of shock. So if they're in a state of shock, there's a limit. So we have 25 professional groups and 1 week of theoretical training and 4 weeks of practical hands-on treatment. What about emergency care? What about intensive care? Today, these executives who worked in this mission benefited the same as expats from the skills to be able to respond to the requirements of humanitarian needs, whether it be in Mali, in Niger, in Burkina Faso, and Chad.
Voilà, et le docteur... Merci.
Thank you.
Le docteur Bounmi nous a
Dr.
rejoint.
Bounmi has joined us. You are based, you have a fascinating story.
Votre médecine à Lagos, au Nigeria.
You studied in Lagos. You're specialized in pediatrics at Harvard, and you have a master's degree in public health in Paris. And today, you're going into the field to help doctors improve the quality of care. Based on your findings, you make recommendations for improvement through these training courses to help meet specific needs, and you're developing training programs to respond. You were in Chad for 2 months this year, 2 months, and you trained 22 medical staff on the care of seriously ill children in 10 different projects. From your point of view, why is this training necessary?
Merci, Kadi.
Thank you, Kadi.
Good evening, everyone.
Hi, everybody.
I'm going to be speaking in English.
I'm going to talk in English.
ALIMA staff take care of some of the sickest children in the world. In other parts of the world where there are better resources, people faced with similar levels of complexity and severity of illness would have the privilege of longer years of training. They would have more supervision. They would have access to more sophisticated support. But that's not the case in the areas of the world where we work. Additionally, like any other place in the world, the distribution of trained healthcare workers in Africa favors urbanized areas and big cities, such that areas that are in crisis and that are remote, like the places where ALIMA works, are left without the trained healthcare workers that they desperately need. It's a complicated situation, and that's why ALIMA is there. Because we know that training people that already have roots, that are enmeshed in those communities, is a gift that keeps on giving. Not only will they be there to take care of the children, but then they themselves can now train more people. I have seen the effect of training and how it changes the outcomes for children. I have been in Gundam in central North Mali and seen it work. I've seen it in Basalogo. I've seen it in Tuguri. I've seen people change practice, do better, and I've seen children recover because of trainings that we put in place. I'll tell you a short story. One time, I was in Tuguri earlier this year, and while we were having a morning staff meeting, a newborn child, just born, was rushed into the treatment room. He wasn't breathing. And so we all rushed there and did the newborn resuscitation practice. I coached, and the staff worked. And the child made it. Started to cry, started to breathe, fed, did better, went home with his mother. And when we did the debriefing subsequently, one of the nurses said, I have never seen a child survive in that situation where they weren't breathing and we did resuscitation. This was my first time. And I didn't do it. They did. I just coached. And so after that experience, I did a lot of teaching. We used videos. We used mannequins for simulations. And just worked on strengthening their capacity to resuscitate newborn babies who are born without breathing. And this is what we need. This is what we need to do everywhere. This is what we need to do all the time. We face challenges of not having the right equipment. We face challenges of not having the appropriate materials that are adapted to the language, the culture, and the situation. We face challenges of not having the right people with the right skills to transfer in those settings. But we can fix this, we can make it better, but we need your help. If you support us, like some of you have done before, we can make this happen. I want to thank you for listening, thank you for being here, and thank you for your support.
Thank you. Thank you so much, Dr. Bunmi. La formation, la transmission des pratiques, ce sont des informations importantes. C'est un
Transmission of practice is a major pillar in the ALIMA work, but it doesn't stop with that. It also continues in the community, and this is an essential piece of work. Let's have a look. Working with communities. We have to train the mother because we don't want the child to come back, so we have to train the mother. We really need to raise awareness to people to change their behavior. So raise awareness on the part of the mothers who come with their children to the new health structures that we have set up. we imagined a simplified approach, which is based on mothers and families who provide a diagnostic at the home. They use a ribbon on the arm to make it easier to identify the child, to check their child. They can check the size of the arm. It's essential that the tool that's used by the families is good to diagnose malnutrition. Is the same tool that's used by the medical personnel in the health centers, so that parents can identify way upstream if a child starts to get thinner. They can bring them to the center. So they've already been trained on measuring the radius. And they can also talk with people that live in the neighborhood, so they can also provide this information to people that live near them. So you can, and if there's a problem, they can bring them to the health center that's the closest for them. It makes it easier to detect more cases of malnutrition that are in the same town where they live, in each house, or in each, and then they will refer people to us in case of need. Humanitarian aid is often seen as a direct response to an emergency, but in truth, there is also prevention work. There's awareness raising upstream, which increases the impact and the transformation of behaviors in depth. Dr. Rodrigue Alinatu, who is the regional coordinator of the Optima project, which is a transformative project led by ALIMA for the management of malnutrition. Good evening, Doctor. How and is ALIMA building projects for families and mothers of families? It's fundamental. But you know that for some time now, we've had a dehumanization of healthcare services, both in the public sector and the private sector. The patient has become a client, and we're more interested in something other than what they need in terms of care. But listening to them and involving them is really the basis of any medical activity or paramedical activity. Let me paraphrase Louis Pasteur, who said, care sometimes, treat often, and always listen. So you have to keep this human face on care workers, to serve the community by care and also by listening. And this translates and to think about the patient first. But why mothers? Well, if you talk about a patient, you talk about a community. And this is many families. And if we talk about families, the mother is the guarantor of the well-being and the health of the family. That's why in health promotional activities, we have mothers in the PB so that they can identify malnutrition as far upstream as possible, as early on as possible. So in the case of N'Djamena, awareness raising is a way of reducing the risk of malnutrition in the population. So all of these activities are of great importance. But the community in general needs to have an appropriation and a raising of awareness more globally, especially having a response strategy with and for the community. That's why and how we work on prevention. So what are the benefits, Dr. Alitanu, of the work that's anchored in the community and with the families? What are the benefits of that? With this model, in our experience, this is you can't estimate it in terms of health and nutrition, in countering epidemics, and in research. So there is a very central activity making it possible to save thousands of children every year. I can also give you some information about research, which is a simplified care for certain patients. So these research products, right from the beginning, was put together with the community through an unprecedented dynamic. And it's thanks to the comprehension of and their involvement of these communities at all level of the implementation that today that we are building proof in Central Africa and the Sahel and Western Africa to cover thousands of Ant that didn't have access to healthcare before. So the benefits are inestimable. I'd like you to talk about the Optima project a little bit. Could you talk to us about Optima?
On vous a perdu.
I think we lost you. We lost the sound. We'll come back later. About the Optima project, we're going to come back to that. It's a research project that is dear, and Dr. Susan Schiffer is with us in New York. We're going to talk about it with her in just a moment. But first of all, let's look at a video about the research project. Let's have a look. One of the main founding principles for ALIMA is to move forward in medicine for the populations for whom we work. When I started 15 years ago, care for malnutrition had just changed a lot with the arrival of ready-to-use food, which made it possible for the mother to feed their children at home. And the existing protocols for 20 years use a constant dose, and the child took on weight, and they got better for a few weeks, and then the weight made it possible to stabilize them. But we observed that the TPE is what cost the most. It's more than half of the cost of the program. So why continue to give so many rations rather than making good use at the beginning and then reduce that dose little by little to accompany with the ratio with just one sack. So that's what we've been using. We started in Burkina Faso in 2017. For example, in Bamako, we were able to demonstrate that the percentage of malnourished children that were treated in the year went up by 40% to 55% a year later. Here in Chad, with the supply chain, which is difficult, I think it's going to be a very great asset, both for families, for children, and for the health ministry, because they can have a program that's better adapted to the context here. Thank you. Now let's go to New York and to see Susan Shepard, who's going to be speaking to us a bit more about her research project. Good evening, Doctor.
Bonsoir, Kadi. Bonjour de New York. Pour être plus concise, je vais continuer.
I'll be short. I'm going to continue in English.
So, as you have likely guessed, the reason that I just spent 3 weeks in Chad last month is because we're starting this innovative program to simplify the treatment of acute malnutrition that we call Optima, for optimizing the treatment of acute malnutrition. And with this project in Chad, we aim to treat 35,000 children next year. And the reason why this is a realistic goal is because of all of the work that ALIMA has invested in clinical and operational research since its inception. My first assignment with ALIMA was back in 2014 during the Ebola epidemic in Guinea. During that project, ALIMA and a team from INSERM at Bordeaux put in place a clinical trial to test an antiviral medication. And from that initial project, from that starting point, ALIMA and the team in Bordeaux has built a very close research partnership and we apply rigorous research methodology to the pressing medical questions that we encounter in humanitarian practice every day. We call this partnership CORAL, for the Clinical and Operational Research Alliance. And this partnership would not have been possible without private donations. We were able to use private donations, leverage them with operational funding to finally put ourselves in a position to obtain funding specifically for research in humanitarian contexts. So these new projects in Chad are the result of more than 5 years of research done through CORAL. We have conducted a combination of pilot studies and randomized controlled trials that are demonstrating that this simplified approach to treating malnutrition, is explained in the video, based on MUACs and family detection of acute malnutrition, is equally good and likely better than current practice. So we've shown that families are equally skilled as community health workers at screening their children. We have shown that nurses in health centers are quite capable of applying a new protocol that adjusts the dose of therapeutic food as the child progresses towards recovery. And this altogether results in a more efficient program that makes best use of resources, of expensive resources like nurses' time and therapeutic foods. It allows us to treat more children while lowering the cost per child. And this, of course, in a setting like Chad, where there's so many children to be treated, is going to be absolutely key to getting care to those who need it most. So there's a randomized trial that we did in Democratic Republic of Congo, which is now submitted for publication and should appear soon. Health economists here in the US are performing cost effectiveness analyses. A similar trial in Niger will conclude in 2022. Results are already beginning to influence practice, and our published work will certainly inform policies in West and Central Africa, and almost certainly also at the international health level at the World Health Organization. I would be remiss, though, if we just focus. I know we're focusing on malnutrition in Chad, but the other area where ALIMA-associated research has been so impactful is in emerging infectious diseases, and specifically Ebola. So we touched on the Ebola epidemic in 2014. That was kind of the starting point for all of for most of our research work. But building on this expertise, my colleagues have run Ebola treatment centers in Eastern Congo, primarily in the 2018-2020 epidemic, and these treatment units have served as clinical sites for the PALM study, which was run in collaboration with the National Institutes of Health. We identified 2 monoclonal antibodies that were effective in reducing mortality in Ebola patients, dramatically improving prognosis for which is a terrifying disease. In Guinea, we've been running clinical trials with the National Institutes of Health and INSERM for Ebola vaccines. This has already changed the way that we practice. It has improved our ability to respond and control epidemics, unfortunately more and more common. Also in Guinea in 2022, we'll be a partner in a COVID-19 vaccine trial, and we published one of the few COVID case cohorts from the African continent from our work in Conakry and Ouagadougou in 2020. ALIMA is also in partnership in Nigeria to document the clinical course and try and identify new treatments for patients with Lassa fever.
Thank you, Dr. Shepherd.
Just want to going forward. One last paragraph. Just want to conclude on saying that everybody has the right to benefit from medical research, and that research that seeks to improve the health outcomes that are specific to the circumstances where they live and address the particular health problems they encounter. At its beginning, the humanitarians who founded ALIMA understood this huge gap. With the ALIMA model for partnership, and including the people who are in this forum tonight who have done so much to support this work, we are beginning to see the fruits of this ambition. I want to thank you very much from the bottom of my heart.
Thank you. Thank you so much, Dr. Shepherd.
These research projects are of great importance and make it possible for ALIMA to change protocols and to transform humanitarian medicine, because the daily occupation of ALIMA is a very long time of research, but also emergencies. And we're going to see emergencies on a daily basis. Let's have a look.
Au Tchad, on a eu à reprendre beaucoup des urgences. D'abord, on a
Well, talking about emergencies in Chad in 2014, with the refugees from N'Djamena in the south of Chad, in this zone, there were a lot of emergency operations. I just saw your mail. Could you come tell me a bit more about this emergency? It's a movement of population, 15,200 people. So you're going to send a mobile clinic to do an initial assessment. So they tell us where there's an emergency, and we have a part of our logistics inventory here with pumps, so that we can intervene very quickly from a logistics point of view. We're going to set up a central pharmacy here. We have gas for emergency reasons. So we're going to be sending a vehicle out with medication to try to bring everything they need. So this is for 1,000 patients. So the inventory is mobilizable in 7 days. We can hold out long enough so that we can bring more inventory in. And the mission that's here, faced with this situation, can do something right away before the direction of operation, provides behind that. So it's really the best way of handling this for the beneficiaries of these treatments. Let's head back to Dakar, to our set there with Tijan. It's over to you. Thank you, Kadi. Emergencies are the daily work of ALIMA in the field. I'm happy to have with me here Dr. Papis Lam. Everybody calls him Dr. Papis, who's medical head of the emergency department for ALIMA. I know I've called you many times this summer. It was hard in Dakar during the COVID crisis, and we had some ALIMA people that were there to help. I was panicked. It was complicated, and you're the one we called every day. How do you handle that? Good evening, everyone, and thank you for handing over to me. ALIMA, we intervene in an emergency situation often, but the question is, what is an emergency? Because these are situations that are unusual and serious, severe, that happen suddenly, but also they can be situations that happen gradually. And these situations, the life of communities, because this can increase the suffering of the population at large because there are more deaths. So ALIMA intervenes in several types of things. I'll cite epidemics such as Ebola, cholera, or others. But there's also many injured can wind up in emergencies. There are natural catastrophes like tsunamis or a volcano that erupted not long ago in the north and the Democratic Republic of Congo, and also just movements of population. Let's focus in on those displacements. Just imagine that there are people or communities that from one day to the next have to pick up and leave. They're going to walk several kilometers away, far from home. They no longer have access to food, to the earth, and to drinking water. And they have no place to live. And those populations are more than vulnerable because they develop diseases such as diarrheas because there was not drinking water. They live outside, so it's complicated by mosquitoes. Thus, it could be increased cases of malaria and other diseases and malnutrition because they don't have access to food. So, ALIMA, we respond to this type of emergency, and I can already say that we were supposed to do more than what we're doing today because you don't have the resources to do more. But concretely, what does ALIMA do and how do we proceed? Well, we already receive information that we call alerts in several ways. It could be via the administrative authorities or the communities or even the international NGOs or the United Nations. And we check the information, and if the information checks out, then we send in an exploratory mission. We send, physicians, nurses, and logistics people local to see what the reality is. And the purpose of that is to confirm in the field the information that we received, and if the information is confirmed, to be able to measure the extent of the situation. And if it is extensive and confirmed, and if we need to intervene at that point, we'll deploy a bigger operation. We will send out more staff, physicians, nurses, and health and drainage personnel to provide assistance to the population. And we have health care, we've got nutrition. We can also assess sexual problems, gynecological problems. But when people leave their natural home, they don't know what's going to happen tomorrow. So they're really suffering from uncertainty. So we need psychological support, and that's an important part of what we do. And we have to try to help them and reinforce that kind of support. So ALIMA supports communities. They work in health centers. We also work in hospitals by drawing a bond between the community and the health centers and the hospital by supporting a referencing system. Thank you.
Merci, Dr. Papis.
Thank you, Dr. Papis.
Je sais que vous n'en faites pas.
I know that
Vous l'avez dit.
you don't do enough. I feel that frustration. I understand. You feel that every day.
Pour moi,
For me,
tous les membres du comité,
the members of the committee, the objective
vous n'ayez plus à faire ces
is that you don't need to arbitrate anymore. You don't need to triage. You can do more. And I think that's the purpose of this evening's meeting and the three funds here that we're supporting. I think it's important to remind people of that, even if it seems far off. From one moment to another, we could need you, and thank you. Thank you for what you do. Thank you so much. Thanks to all. Thank you, Tijan. Where do we stand in terms of the donations? We've moved forward. Thank you. 114,779,000. We're far away from our goal, but we're counting on you. We're persuaded that we will move strongly and reach our objective.
Merci, Kadi.
Thank you, Kadi.
Alors, à travers ces interventions,
via these interventions, we've shown you what the daily life mission is like
sur le terrain, donc
in
sur
the
nos
field.
missions. Alors, vous l'avez remarqué,
as you've seen, there are a lot of difficulties that we face. But this doesn't stop us to always try to do better and to meet the needs on a daily basis. I'm going to invite you to have a look at the next video to explain why we need to be part of the solution to the difficulties that we have to deal with. We're in 22. If funding is not renewed, it means that we'll have to stop the program right in the middle of the year. We have a treatment that's been here for 15 years, and it works to treat children. It's just a question of having access to the resources we need to treat these children. That's what the risk is, which is why we need to find other sources of financing if our other normal supporters don't support us. You start thinking, what do I do in case of an emergency? How do I handle it if there are no more supplies? There are a lot of children that have no access to care. And that's really the consequence. And it's important for mothers that they have access to care. You know, these are real efforts for the families and the real social concern. Statistically, the most revealing statistics are all the clinical trials in the world. They're 2% in Africa, but it's 20% of the population, and where child malnutrition is a real problem and can reach more than 60% of infectious diseases actually due to malnutrition. We have to train mothers here, but that's not enough. We have to train them in every center. We have to keep investing in training of other mothers in every center.
Merci, merci
Thank you.
beaucoup. On arrive à la fin
We
de
have reached
ce
the
moment
end of
partagé
this
ensemble.
particular
Merci,
moment
à
spent
tous.
together. Thanks
À
to
vous
all.
qui nous avez suivis en
For those of
direct
you who have
sur
followed
Internet,
us
en
live on the
Abidjan,
internet from
à
around the
Abidjan,
world,
à Dakar,
in
Dr.
Tijan and
Sven, je peux
Dakar,
annoncer que
Dr.
pour vous,
Shepard,
la
I
soirée
know that
est
for
loin
you,
d'être
the evening
terminée.
is not
Pour vous
over,
aussi, la soirée se poursuit avec
and
les
our
grands
evening is
donateurs.
continuing with the
Merci
big
à tous
donors.
derrière vos
Thanks to
écrans.
all behind your
Merci beaucoup
screens.
à vous ici, là-bas.
Thanks to all of you
Encore
here
sur vous
and
pour
there.
atteindre et dépasser peut-être
And hopefully we'll be
l'objectif que
exceeding
vous
our
avez fixé.
objectives.
Moumouni, un dernier mot.
Mimuni,
Merci
one
Kadi.
last
Alors,
word.
je
Thank you,
voudrais,
Kadi.
tout humblement vous dire
I would
un
just like
grand
humbly to
merci,
say
d'être vraiment
thank you
ici,
all.
avec nous.
Thank you for being
Merci à
part
tous
of our
ceux qui
new
nous soutiennent
Humanitarians.
depuis,
Thanks for
plusieurs
supporting
années. Ça
us
fait
for
12
several
ans
years.
qu'ALIMA existe. Ça fait
ALIMA has been
12
here
ans
for 12
que nous
years.
relevons
It has been
chaque année,
12
on va
years that
dire,
we
des défis.
do a
Je
fundraiser.
voudrais
I'd
particulièrement
like to
dire ceci.
particularly
Alors,
say
pour
this.
chaque million d'euros
Each million
que
euros
vous mobilisez
that you
pour
mobilize
ALIMA, ça
for
nous
ALIMA
permet justement
makes
de
it possible
pouvoir
for
lever
us
10 millions d'euros
to raise
auprès de
10
bailleurs
million euros
institutionnels.
from
Donc, vos dons sont
institutional
importants.
investors. So your
Je
gifts
vous
are
remercie
important.
très
Thank you
chaleureusement.
very warmly
Merci encore.
for your help.